Hello everyone, this is the ABG series scenario 8 brought to you by the Medicine Project. Let's take a look at this case. A 19-year-old girl with a history of diabetes on insulin therapy was brought to the emergency with altered sensorium, shortness of breath, and fever. Last night, the patient had apparently eaten about 5 pieces of chocolate cake as a dare and presented with the following complaints on the next day in the afternoon. She had missed her last 2 doses of insulin as well. The patient had history of fever 2 days back. On examination, BP was 100/60, pulse was 117, chest was clear on auscultation. Patient was shifted to the ICU and a urinalysis revealed ketone bodies to be positive. Now, a history of fever is important to keep this case relevant. I'll explain further why. For now, let's take a look at the ABG. So pH is 7.12, PaCO2 20, PaO2 98, bicarbonate 6, lactate 1.8, sodium 130, chloride 92, and sugar was 520. Let's analyze the ABG disorder in this case, check the anion gap and the management of this patient. So this patient is a case of pure high anion gap metabolic acidosis with partial respiratory compensation. The anion gap in this patient based on the formula that I've mentioned here equals 32. Furthermore, if we closely observe, the fall in the bicarbonate or delta HCO3 is 24 minus 6, that is around 18, and the delta anion gap is 20. Therefore, anion gap delta is similar to the delta bicarbonate value, suggesting that this is a pure high anion gap metabolic acidosis and not a mixed disorder. So the management of DKA has been noted below. You can take a screenshot if you want. I'll just highlight a few important points. So firstly, we diagnose the precipitating factors, check the severity of the patient. Electrolyte assessment, especially of potassium, has to be done. Fluid replacement has to be cautious. Always watch out for risk of pulmonary edema. Further, if the patient is on a fluid restricted regimen, avoid giving aggressive fluid boluses. Start regular insulin infusion at 0.1 units per kg per hour and assess the glucose and the anion gap. Always check the potassium status before starting insulin. Do not give insulin if the potassium levels are less than 3.5. We have to correct it first and then continue insulin infusion. Assess potassium every 2 hourly in this situation. Now continue this until the patient is stabilized and target glucose of 150 to 200 is reached. Anion gap has to be stabilized, and once the acidosis resolves, lower the infusion rate. Resolution of euglycemic decay, however, is determined by the bicarbonate levels. Now once the patient starts eating, start administering long-acting insulin and overlap it with the IV regimen. Always remember that insulin deficiency is important rather than isolated hyperglycemia to cause DKA. Thank you. Please like and follow.